So I'm going to get started just because I want to make sure that everybody can have their full evening tonight. Just want to introduce myself. My name is Jen Margalis. I am the project owner handling our clinical panel series here at LARVOL. And thank you so much for joining our panel discussion. World Lung just finished, and we are going to be covering some lung cancer abstracts. And I wanted to start by introducing the panel that we have with us today. So our moderator is Dr. Mark Awad. Dr. Awad is an assistant professor at medicine at the Harvard Medical School and clinical director at the Lowe Center for Thoracic Oncology at the Dana-Farber Cancer Institute. Our panelists are Dr. Ticiana Leal, associate professor of medicine and director of the Medical Thoracic Oncology program at the Winship Cancer Institute at Emory University School of Medicine. And last but certainly not least, Dr. Josh Royce, my apologies, thoracic medical oncologist at Georgetown Lombardi Comprehensive Cancer Center and assistant professor in Department of Medicine at Georgetown University Medical Center. So I want to thank all of our speakers for being here. We are super excited to hear from you as you discuss the impact of the selected abstracts from this conference. And thank you to all of our audience for joining us this evening. So with that, I will hand it over to Dr. Awad.
Well, thank you so much, Jen. Very nice to be with you all here tonight, and thank you to Dr. Leal and Dr. Royce for participating. I think we'll have an interesting discussion over the next 30 minutes as we discuss 3 abstracts. And we'll start first with Dr. Leal. We can talk about the abstract on amivantamab in MET exon 14 mutant lung cancer from the Chrysalis study. So I wonder if you wouldn't mind taking a minute just to kind of summarize at a high level the basic study design and initial results. I think Jen is kindly sharing a slide or two from this study as it's starting to share the screen here.
I am trying here. Let's just give this one more second.
So I'll start out just saying that these are just initial results from the cohort from the Chrysalis study. We've seen amivantamab recently approved for exon 20 insertion mutations. And amivantamab, I'll summarize it calling AMI for short moving forward, is a bispecific antibody that targets both EGFR and MET. And interestingly, it actually has higher affinity for MET than EGFR. And what we saw at WCLC was the initial results for the cohort for patients with the MET exon 14 skipping mutation. And what we saw was the initial results of 19 patients. This study with the expansion cohort actually hopes to accrue and will accrue 100 patients. So what we saw is the results of 14 of 19 evaluable patients and a very promising initial response rate of 64%. The median treatment duration of amivantamab in this patient population was 6.5 months, and the median duration of response was actually not reached in the study. In terms of the patients who achieved a response, we saw that patients that achieved a response actually continued to remain on therapy when the study was presented. And in terms of safety with this study, the results showed similar safety that we've seen in the exon 20 population, and the grade 3 or higher toxicity rates was 16%, discontinuation rates of 5%, dose reduction of 11%. I think in terms of identifying the MET exon 14 in this study population, they actually identified the MET exon 14 by NGS or by circulating tumor DNA, which I think is awesome that they included both, because that's what we're doing in clinical practice and in real life. And this helps us sort of really know if that's how we should be using it in clinical practice. Is this a practice-changing presentation? I would say not yet. We currently have 2 agents that are approved by the FDA for the MET exon 14 skipping patient population with non-small cell lung cancer. We both have capmatinib and tepotinib that are already FDA approved. We know these are very effective agents. The overall response rate in the previously treated population, which is the same here for those 2 agents, are in the 41 to 43%. And we've seen in the previously untreated population with capmatinib higher response rates. But again, this is a study that is preliminary results. We're only seeing 19 patients, so not yet practice changing. However, certainly very promising to see AMI in this patient population. So this therapy, in my opinion, is not something that I would recommend yet for our patient population with the MET exon 14 skipping mutation, but certainly would like to see the ongoing results of this study at future meetings. In terms of challenges associated with this therapy, just kind of moving in terms of safety, one thing that I think is interesting to compare it with the standard of care that we currently have, the grade 3 events with peripheral edema are much lower with AMI. So this may be an option if toxicity becomes an issue for patients on the standard therapies, capmatinib or tepotinib.
Thank you very much for an excellent summary and putting it into the context of the larger treatment paradigm for MET exon 14 mutant lung cancer. Maybe I'll ask Dr. Royce about on this topic. So, of course, we are getting new targeted therapy approvals all the time for lung cancer, which is very exciting. And we've got tepotinib and capmatinib available to treat MET mutant lung cancers. I think what was exciting about this study is that it also, as Dr. Leal mentioned, included patients who had prior MET-directed therapies. And we saw some activity, albeit it's a very small cohort, we saw some activity of amivantamab, whether patients received prior MET inhibitors or not. Maybe, currently, when you have a patient with MET exon 14 mutant lung cancer and you've treated them already with a MET TKI such as tepotinib or capmatinib, what's your approach after they develop resistance to a TKI, or what subsequent therapies outside of a clinical trial do you think about for these patients?
Well, I think, for these patients, there's still some other options. Obviously we have chemotherapy in our back pocket. That's always something that's there. These are not patients that I would necessarily withhold immunotherapy for. I think that this is a population also that there's a higher rate of smoking. There are other variables, I think, that potentially suggest that immunotherapy would benefit these patients. So it's right now, it's a patient population that I would definitely consider an IO chemo approach for. But obviously, as amivantamab emerges onto the scene and as it is already approved for exon 20, I would definitely fight for off-label use for amivantamab, even with this limited data, because I think it is a good option for our patients.
Yeah, I think,
in my opinion, this is evolving. I think we'll hopefully find out more about mechanisms of resistance through the Chrysalis studies as we get more patients on. I think the results are still very preliminary to really know how do we sequence these therapies. If a patient receives capmatinib, will they then be able to receive benefit from AMI? I think it'll depend on resistance mechanisms, and certainly I think we need more data to truly understand and make recommendations on sequencing.
I think it's a great point, and we can apply that also now to the EGFR exon 20 population, now that we have, as of yesterday, a second agent approved with mobocertinib as well as amivantamab. How do we know how to sequence these therapies one before the other, or are they just as active in either order? Dr. Royce, you were going to say.
Oh, no, I was going to say, and I think as Dr. Leal pointed out, I think what's great about this study too is that it included patients with prior TKI. So hopefully we'll get more of that answer as we see more and more patients that are enrolled will likely have progressed on tepotinib or capmatinib. So hopefully we'll be able to get an answer there. I think the other outstanding question is, what sorts of responses are we going to see in patients who have baseline brain metastases? I think we have data that tepotinib and capmatinib have CNS penetration. It suggests CNS response, though there's not obviously a lot of data on that yet either. But I think that'll be another interesting variable to throw in here in terms of sequencing, patients who have brain metastases, and then obviously other variables for patient preference. I think most patients would prefer to take a pill every day than to come in every 2 weeks for an infusion. But, still obviously a lot of data and remains before being able to make those recommendations.
Great. So I think seeing some maybe very early but potentially promising signal of activity for this population that's in need of new therapies or additional therapies, but I think still a little bit too early. I know in the waterfall plot presentation on this study, 4 of the responses that they reported hadn't yet had a confirmatory scan. So it's still very, very early, but we'll stay tuned for updates on these data at future presentations. So maybe with that, we can move on to the second abstract, and I'll ask Dr. Royce to present some of the updates on Empower 010 in terms of use of adjuvant atezolizumab in resected lung cancer.
Sure. So I'll be brief so we can get to our discussion. So Empower 010. So this presentation by Dr. Al-Turki at World Lung this year was kind of a modified encore presentation. So looking at the characterization of stage 1B to 3A patients by type and extent of therapy prior to adjuvant atezolizumab on the Empower 010 study. So recap, this was a trial of adjuvant atezolizumab or best supportive care in patients with resected stage 1B to 3A non-small cell lung cancer. This was a positive study with results presented by Dr. Wakely at World Lung earlier this year. And what this presentation gave us was a little bit more detail on baseline characteristics and some subgroup populations that provided a little more food for thought. So in terms of interesting data from this presentation. Number one, it appeared that about 20% of patients that initially enrolled on the study actually withdrew prior to randomization, of which about a third withdrew consent and 20% had disease relapse. When looking at demographics, these were actually very balanced by surgical type, by median time from surgery to adjuvant atezolizumab or best supportive care, and then other surgical characteristics like median sentinel lymph node dissection were all well balanced. When looking at other variables, chemo compliance was actually quite high. The majority of patients received 4 cycles of adjuvant chemotherapy, though of note that was lower in those who received cisplatin and gemcitabine at about 77–78%, and highest in those who received cisplatin and docetaxel at about 95%. Then when looking at the disease-free survival breakdown, I think that's where you get some interesting food for thought. So it appeared when looking at subgroup analyses that disease stage and regional lymph node status did not appear to impact the benefit for adjuvant atezolizumab. But then when looking at type of surgery and chemotherapy that was received, now again, you must interpret these subgroup analyses with caution, but when looking at this, those who received pneumonectomy and bilobectomy, the benefit was less clear. Again, smaller sample size, wide confidence interval, and there are definitely a lot of variables that could complicate that picture. You know, for those who received a pneumonectomy, was the surgery more complex? Did they then not receive as much adjuvant chemo or adjuvant immunotherapy? I think those are open questions what one must think about when looking at that. And then when looking at chemotherapy regimen that was received, interestingly enough, there appeared to be a less clear benefit for those who received cisplatin and gemcitabine. And again, less patients received the full 4 cycles who got cisplatin and gemcitabine. So did that impact this? Is it have to do with the histology, squamous histology? Are there other variables? Is gemcitabine less immunogenic, immune activating with immunogenic cell death? Those are all some interesting food for thought, again, from these analyses. But, you know, overall, we'll get into the discussion in terms of practice changing and things. I definitely have a lot to say on that, but those were really the main points from this abstract.
Thank you very much, Dr. Royce. I think, you know, certainly the resected lung cancer population has such a high risk of recurrence, and this is a population for which the standard of care hasn't changed in years. So it's exciting to see that we may be moving the needle with both adjuvant immunotherapy approaches as well as some neoadjuvant approaches or immunotherapy both before and after surgery. So maybe I'll ask Dr. Leal, if you're reviewing these data at the FDA and you have to decide on an approval, is disease-free survival enough to approve an adjuvant therapy? Do you need to wait for OS data? And then also, you know, we see so many different populations in addition to the intention to treat population here of the all-comers. Would you consider approval of this agent for the stage 1B to 3A population, for a subset, for the PD-L1 positives, negatives? How do you interpret many of these analyses here?
Okay, so lots of great questions. I will say that we have had approvals in the adjuvant setting already based on disease-free survival, with the approval of osimertinib based on disease-free survival benefit. So I do think, you know, we have that historically as a potential. Obviously, overall survival would be amazing, but I think in light of the data that we have and the benefit that we're seeing, I personally think disease-free survival is a reasonable endpoint and would favor approval based on disease-free survival benefit. I do want to see a little bit more of the PD-L1 breakdown here, because I think when Heather Wakely presented these results, there clearly was sort of a higher benefit the higher the PD-L1 expression. So it would be, I think, important to know, especially as we get in the stage 1B, that benefit with the PD-L1, would that be something that would change kind of our decision on magnitude of benefit based on PD-L1 and stage of disease? So that would be something that I'd want to know a little bit more about. But I do think this is practice changing. I'd like to see some of the combination strategies of chemo IO, because I do think this is a lot of therapy for our patients. So is it better to give sequential therapy? Is it better to give combination therapy in the adjuvant setting? That's a question that I think is still sort of unanswered. But I do think this is practice changing. I would say that PD-L1 needs to be better defined here as a biomarker. I think, you know, the safety of the sequential therapy here is well established. We've also seen here that there wasn't any compromise in surgical outcomes. So I think overall practice changing, and I think we may see some approvals in the future, perhaps.
Dr. Roy, similar questions to you. If you're seeing a patient tomorrow in clinic, I know this therapy is not approved yet in the adjuvant setting, but who would you consider using this for? And which stages, which PD-L1 levels, or how do you think about this when you're seeing patients in clinic?
Yeah, so I definitely agree with Dr. Leal, what she said. I echo what she said about disease-free survival. I think it's very encouraging that disease-free survival will translate into an overall survival benefit. I mean, I know we have, ADAURA as a kind of a benchmark now for approval based off disease-free survival, but just knowing the mechanism of immunotherapy, the ability to induce a durable immune response and immunosurveillance, I think knowing that mechanism, I do suspect that a disease-free survival benefit will translate into an overall survival benefit. But again, that remains to be seen. I think, it's an interesting question. Again, as Dr. Leal mentioned, the benefit did appear to be incrementally greatest in those that were PD-L1 high, 50% or greater. But we also know that PD-L1 is an imperfect biomarker. Those are additional things that we need to learn and discover. I think the PD-L1 positive population for sure is one where I would consider this. And if I was playing FDA for a day, I think it's likely that we'll see the approval in the PD-L1 positive stage 2 to 3A population, but whether that will then be brought out to the all randomized, I think we need more data on the PD-L1 1 to 50%, which hopefully is upcoming. But in terms of the other questions, I think that, to address, I think this is something that will be practice changing. I think the very interesting question that we might not have time to discuss today is neoadjuvant versus adjuvant. I think there's something to be said about intact tumor burden being important in eliciting an immune response with immunotherapy. And I think if we can combine this, with 4 cycles of chemo in the neoadjuvant setting and then see strong pathologic response, we're already seeing that data emerging from neoadjuvant studies. Now, whether pathologic response correlates with disease-free overall survival remains to be seen. But I think the emerging pathologic response data from the neoadjuvant setting is also really encouraging and something that we'll have to keep our eyes on when we're deciding between a neoadjuvant and an adjuvant approach.
Yeah, I think still a lot to come in discussing neoadjuvant adjuvant therapies with patients. How much treatment is too much? How much is too little? You don't, of course, want to expose anyone to a therapy that they don't need because some of the toxicities can be more serious. So I think a lot for us to digest with some of these emerging studies as the data become presented. Dr. Leal, do you think there could be a scenario in which the patients don't receive chemotherapy and can just get immunotherapy in the perioperative setting or in the adjuvant setting?
I definitely think that there's always that chance. When we look at some of the studies, we see that there are patients that are not eligible or decline, chemotherapy. So I do think that in clinical practice, we'll see that scenario. And certainly, I think it's an important discussion to have with your patient. But I think if the immunotherapy is approved and the patient is not eligible or declines chemotherapy, that's certainly something that we'll have to discuss with the patient. And I would still offer immunotherapy, in that setting as well.
Great. Well, maybe for the next 10 minutes, we can move on to the third abstract, and I can give a brief summary of the Poseidon study, which we have some data as shown here. So this was a phase 3 trial in metastatic non-small cell lung cancer where both squamous cell carcinoma and non-squamous non-small cell lung cancers were included. Patients were negative for EGFR and ALK. And here there were 3 treatment arms with a randomization of 1:1:1 of platinum-based chemotherapy. And they did allow up to 4 cycles of chemotherapy. Or another arm was chemotherapy plus durvalumab for 4 cycles, followed by maintenance durvalumab and pemetrexed until disease progression, not necessarily limited to 2 years of therapy. And then the third arm was incorporating the CTLA-4 inhibitor tremelimumab with durvalumab and chemotherapy for 4 cycles, followed by durva, tremi, pemetrexed until disease progression. And here, the primary endpoints were comparing progression-free and overall survival just of the durvalumab chemotherapy arm to the chemotherapy arm. And the secondary endpoints were looking at the contribution of tremelimumab. And I think in this study, they demonstrated that looking at the PD-L1 alone, so the durva chemo arm, there was a significant improvement in progression-free, but not overall survival. You can see here on the left this non-significant trend towards OS benefit, but didn't meet their statistical primary endpoint. And then interestingly, with the addition of tremelimumab to durva and chemo, here we saw an improvement in progression-free as well as overall survival. And they thought that in subgroup analyses that the benefit of durva tremi with chemo may have extended more in the non-squamous population, as you see in this forest plot on the right, as compared to the squamous population. And here again, we see that never smokers don't necessarily seem to benefit from the addition of immune checkpoint inhibitors to chemotherapy. And some of that has been borne out in other studies, but former or current smokers seem to have had a greater benefit. And then again, we see that the PD-L1 expression level does have an impact on outcomes, whether that's the addition of durvalumab alone or durvalumab tremelimumab to chemotherapy, with notable improvement, particularly when the PD-L1 levels are higher of 50% or greater. So I think here, this is another study of immunotherapy, chemotherapy combination in the frontline setting. And now we've got many trials to think about and consider in the frontline setting. So in the next few minutes, maybe I can ask Dr. Leal first, and then Dr. Royce. So, we've got many agents, some of which are approved, some of which may be approved. So we've got chemotherapy and pembrolizumab. We've got chemotherapy with ipilimumab, nivolumab. Potentially, if we get an approval of chemotherapy and durva tremi, these are several options. We also have atezolizumab-based regimens with the Empower 150 study of carbotax bev, atezo. And of course, we've got a lot of monotherapy immunotherapy agents approved of pembro, atezo, cemiplimab, ipi-nivo, many options to choose for our patients. How do you wrap your mind around all of these available options? Is this one going to be practice changing? Is there a particular patient population in whom you would choose the Poseidon regimen for, as opposed to any of these other treatment regimens that we mentioned?
So I think this is a super crowded space in the frontline setting, and I'm going to go back to Keynote 24. We've been using it for a long time. We've seen the benefits of monotherapy in terms of responses, survival, as well as tolerability and quality of life. And so I think for the PD-L1 high expressor, I remain kind of really more in line with monotherapy for patients that have high PD-L1 expression. Either pembrolizumab or atezolizumab PD-L1 inhibitor can be agents that can be used in the monotherapy frontline setting for the PD-L1 high expressor. I think we're still figuring out how to incorporate, the CTLA-4 inhibitor in this combination strategy here. I still want to know who is the person that really needs a CTLA-4 inhibitor. And now this kind of muddied the water a little bit because of the way that this was done, where we have 5 doses of Tremi with 4 cycles of chemo versus what we did with Nivo plus Ipi plus chemo, where you actually have 2 cycles of chemo and then ongoing CTLA-4 inhibitor. So in my mind, I want to know a little bit more in terms of who is the patient that really needs the CTLA-4 inhibitor. I think when we thought about checkmate studies, we were kind of trending in the direction of maybe it's the PD-L1 negative, maybe it's the squamous PD-L1 negative. We saw really impressive hazard ratios for the squamous PD-L1 negative with the checkmate studies. But now we look at the Poseidon and we look at the PD-L1 negative population, and you're not seeing that same trend in the PD-L1 negative population. And then we saw the curves for the squamous population, and the squamous population, the curves were really disappointing. So to me, I was thinking maybe for the PD-L1 negative squamous population, the combination strategy with the CTLA-4 is really the way to go. This study doesn't really reinforce that message. So I do think that we see the survival benefit here. Is it worth the extra toxicity of the CTLA-4 inhibitor? What's going on there with the PD-L1 negative subgroup and the squamous subgroup? I still have a lot of questions about that. So potentially practice changing. It's just going to be hard to incorporate that into clinical practice, given all the other agents that we have and kind of how late in the game this combination is coming in.
Dr. Royce, where do you fit this study in with the greater context of all the other trials that are already out there, some of which are approved?
Yeah, no, I think I will sound like a broken record following Dr. Leal again, but I think, as Dr. Bramer put in her discussion, it's a great time to be a thoracic medical oncologist. You do feel like a kid in a candy store with having so many options, and I feel very fortunate to enter the field at such an exciting time. I think that, again, for the PD-L1 high expressors, I think it's a very clear scenario where PD-1 monotherapy is likely the way to go. I mean, there might be some extenuating circumstances if you have really high tumor burden and you think that the addition of chemo could elicit a more rapid cytoreduction. But outside of that, I think the monotherapy is the way to go. But then when looking at the low expressors in the negative, PD-L1 negative, that's really the population that is the big question mark. And I was just grappling with how to incorporate 9LA and 227 and thinking, as Dr. Leal said, that, oh, well, maybe it's the PD-L1 negative, the squamous population that's going to benefit most from the addition of CTLA-4. But then this potentially throws a bit of a wrench in that, but it might raise some very interesting points. One, that is the continuation of the CTLA-4 important in those who have squamous because the CTLA-4 was not continued in Poseidon study? And again, does the chemo doublet matter? It was the gemcitabine doublet that did not see quite as much of a benefit you see with the slide up here. And gemcitabine doublet was not allowed in 9LA. So does the chemo doublet partner, is that important? And then lastly, I think another population to think about are brain metastases. I know we had data at World Lung presented on 9LA with brain metastases. And so is the CTLA-4 important in helping to maintain CNS disease control? I think that the Poseidon study is practice changing in that it will likely result in another regimen, the Durva-Tremi chemo regimen being added to our armamentarium. But how it will change my practice, I think, remains to be seen. I think we still need more data, and I'm still trying to grapple with the exact populations based off of what I just mentioned, what Dr. Leal said earlier.
Certainly agree. This is a really fast-moving field, and of course, we're already seeing large phase 3 trials being launched to add yet additional immune checkpoint inhibitors on top of our chemo PD-1 backbones, and so we'll have to see how this field moves. I think the question of a PD-1, PD-L1 monotherapy in the high PD-L1 expressors of 50% or greater versus giving chemo plus PD-1 in that population, I think is sometimes a question that comes up: who needs chemo and immunotherapy, who can do well with immunotherapy alone. Hopefully we'll learn information about that from the ongoing INSIGNA study, randomizing patients in this population to immunotherapy versus immunotherapy plus chemotherapy. So very exciting time in thoracic oncology, new drug approvals, new regimen approvals, but I think we'll need guidance as to how to incorporate these rapidly emerging data into our day-to-day practice. So I think with that, we can wrap up, and I'd like to again thank the organizers for the invitation. I'd like to thank Dr. Leal, Dr. Royce for very important and intriguing discussions, and look forward to chatting again.
Thank
Yes,
you.
thank you so much, Dr. Awad,
Thank
Dr.
you.
Leal, and Dr. Royce. We really appreciate your time for joining us tonight for the panel discussion. The replay of this discussion will be available on LARVOL's YouTube channel, and we do have other clinical panel discussions following ESMO, as well as the SITC San Antonio Breast Cancer Conference and the ASH conferences coming up in November and December. So thank you to all our audience for joining us, and again to Dr. Leal, Awad, and Royce for joining us tonight. We appreciate. I always learn so much listening to you guys just go on and on about the abstracts. It's so interesting. So thank you very much.